Hi, this is Joanne Hayes. I'm a nurse practitioner in Alice Peck Day Primary Care, and I'm the director of the Diabetes Clinic embedded in primary care. In 2022, we received a grant from the state of New Hampshire to build the Diabetes Clinic, and we started our work in January of 2023. The goal of the Diabetes Clinic is to support patients and clinicians. We want patients to have access to and clinicians to be able to provide up-to-date standard of care in diabetes care. So we started this project doing lots of things, but one of the things we did was to provide educational opportunities for clinicians. And this is the first of the educational series that we did in the spring of 2023. And I'm recording it now so that new providers can have access to it, and for providers who weren't able to attend the series, that they can also listen to this. The first series is on therapeutic inertia, and it really is the foundation and framework on how we are approaching diabetes care in the diabetes clinic at APD. So the American Diabetes Association has an ongoing initiative called Overcoming Therapeutic Inertia, and the goal is to create a paradigm through which to look at diabetes care and to advance diabetes care. We use this initiative as our framework and foundation for our diabetes grant project, and we continue to use it as our framework and foundation for diabetes care in the diabetes clinic at APD. So let's just talk about therapeutic inertia and what it means. So therapeutic inertia is the lack of timely adjustment in therapy, particularly when goals are not being met. So the ADA recommends an A1C goal for most people to be less than 7%. For some people, it's different, but for the majority of people, to set an A1C goal of less than 7%. And yet, fewer than 2/3 of people reach their goal, and less than 50% of people get to the less than 7%. And the other challenge in managing diabetes and why the ADA is addressing this is because of the time that it's taking for change to happen. So even though patients aren't reaching their goal, it can take months to years before adjustment is occurring. And the reverse is also true, that when we have some patients who are overtreated and we need to de-intensify their treatment, particularly in the elderly, we're pretty slow to do that. So the Overcoming Therapeutic Inertia is a really good framework for us to look at all of those issues. And there's been, over the last many years, there's been so many advancements in diabetes care. And we have clear targets and goals of what we're trying to achieve. We have lots of therapies to choose from. We have guidelines and algorithms. And even despite all of this, we are still not achieving targets. There have been more than 40 new diabetes treatment options since 2005, which is sort of amazing. But even despite the increase in treatment, there's also been an increase in the number of people with an A1C over 9. This is just another way of looking at this data, but it really shows that over time, over the last several decades, we have gotten worse at achieving the goals, and 50% of people are still not reaching the treatment goals. So the ADA strategy of overcoming therapeutic inertia is really to drive timely treatment optimization and to also help patients improve care plan adherence. There are lots of causes and contributors to therapeutic inertia. It's multifactorial. But the most common ones are cited here, which are clinician-related, patient-related, and system-related. So we're going to start with ourselves and talk about the clinician factors that contribute to therapeutic inertia. As we all know that there are time constraints in a busy primary care practice. We sometimes fail to set clear targets. We have concerns about treatments, the cost for patients, and also their side effects. We also can underestimate the benefits of education, self-management, and technologies. We tend to be slow in our adjustment of diabetes care. These are different paradigms in looking at approach to treatment. This is the wait and see approach. And basically, it can take us a really long time before we make changes, up to years before we make adjustments. This is just another way of looking at it, and this is called the treat to failure approach. And what I want to point out here is, so here's diagnosis, and we start with a treatment, and we wait for failure before we add another treatment. So we start with improvement, see worsening, failure, add another treatment. And the most important part of this slide is that this is the therapeutic window. This is the goal down here. And this is over many years, and we haven't approached it. So despite adding treatments, we've never gotten down to the therapeutic range, and therefore we lose the benefit of that early control. We know that early glycemic control has many benefits, and losing that really affects patient outcomes. So this early control is also known as the legacy effect, and early glucose management reduce health risks, and it has benefits for years to come. Even when diabetes control can worsen later on in disease, they are still benefiting from that early glycemic control. This is looking at this in the real world. This is a large practice in California, managed care practice, looking at actual patients and where their control sat in the first year after diagnosis. And we see that if they have an A1C greater than 7, they have worse outcomes. And then if we make that even worse with an A1C over 8, in this real life population, we saw increased mortality and microvascular problems. So this is really the opposite of the treat to fail or wait and see approach. This is called the treat to target approach. And this is really what we are shooting for here at APD, and this is what the ADA is recommending. But the idea here is that early on in disease, we get aggressive with treatment. We can start with diet or monotherapy or what have you, depending on the patient and their other comorbidities. But we want to keep adding treatments until we get to this therapeutic range. And then the legacy effect is shown down here with this red line. Then we are going to have variation of management during that time, but we are doing it within a therapeutic range. And when they go outside that range, we bring them right back down. So, and then we have that legacy effect benefit. And an important part of this is to know, well, what is that therapeutic range? For most people, the goal, and this is what the ADA states, is an A1C of less than 7%. We know that the A1C is not a perfect measure of diabetes control, and now with CGM, we are talking about time and range and other targets, but in general, this is still the goal that we use and use in clinical practice. So what is the A1C goal that is best for a particular patient is really decided on by you and that patient, but a starting place is less than 7%. If there is reason for the A1C goal to be different from that, then you want to be clear on what the goal is with the patient and why it may be different. So these are different things that can affect it. You become less stringent if people have more of some of these issues, and potentially more stringent if they have less. So it's important in that process when we are deciding on the goal that we name it. And we do this early on in disease, and we're clear about what that goal is with the patient and ourselves, and that we chart it so that everybody knows what the goal is for that particular patient. This is just an example of a patient that I see in the diabetes clinic. So you can see the third problem here is diabetes type 2, and the A1C goal is less than 8%. She's an older woman and actually was having lots of hypoglycemia. So she got a lot of education about de-intensifying her treatment, and that we set new goals and assured her that this was a safe approach for her. And the way that you do this in the chart is that you would go to the problem list, go to where the problem is listed, hit details, and then under details where it says display, you can, the diabetes, whatever diabetes diagnosis is there, at the end of that diagnosis, you can just type in the A1C goal. And then you can refer back to it and change it if you need to. So back to the contributing factors of therapeutic inertia, I'm going to continue on the clinician role here, and I just want to discuss for a few moments the last bullet here, which is talking about diabetes self-management. And so I want to spend a little time here talking about what that is and why it's so important. So diabetes self-management is it's an approach. There are ADA standards on this particular approach in teaching people about diabetes, pathophysiology of diabetes, and the management of diabetes. And if someone receives diabetes self-management, then the benefits are many. It lowers A1C, it improves diabetes knowledge and self-care behaviors, it lowers weight, improves quality of life, positive coping behaviors, reduces health costs, less frequent hospital and acute care setting stays, and reduces all-cause mortality. And for us here at APD in the diabetes clinic, diabetes self-management is really the foundation of all care. So we start with diabetes self-management before anything else because it sets up the basic knowledge base from where patients can own their own health and make wise, thoughtful decisions about taking care of themselves. So if we're going to be doing nutrition therapy within that context or other lifestyle interventions, we really start with the basics around diabetes self-management. Diabetes self-management can be utilized throughout a person's lifetime and life of diabetes, but at particular points, it's quite important, particularly at diagnosis. Anybody who's diagnosed with diabetes should have an opportunity to have access to diabetes self-management, education, and support. And then if there are changes in their disease, or if they're not meeting their targets, or they have a transition in life, or things are getting complicated, then they can always come back and personalize their diabetes self-management with a clinician. So if you want to refer to the diabetes clinic for diabetes self-management education, it also includes other things, but in general, if you're just starting with the general referral, what you want to do is type in diabetes clinic to the orders, and this will pop up. Lots of things pop up, but you have to pay attention here. You want to be referring to the diabetes clinic at APD primary care. This is the referral that you want, not diabetes education. That's a system-wide referral, and we do a lot more than diabetes education. And so that referral didn't really quite work for us. After you put in the referral, this is what will populate. And what I want to show you is that then it says referral to general internal medicine. That is not an error. We had to build our referral within an existing referral. We aren't allowed in the system to create new referrals. So we use the general internal medicine referral and then within it personalized it to the diabetes clinic. So don't worry, those referrals do get to us. Then you can, these things actually populate, and then you can put in a particular question if you have it. And then under the comment sections, we have this is the comment sections that we have pre-populated particular reasons to refer to the clinic. One is just general all-inclusive, like please just do a whole approach to this patient, find out what's going on, look at their medicines, look at their lifestyle, see if they can afford medicines, et cetera, et cetera. So you could just do that and we would do everything. If you really just want them, they're doing well, but they want to learn more about food, then you can do nutrition only and asking them to bring in a 24-hour recall. If they only need injectable medication teaching, then you can set that up, or glucose monitoring, including continuous glucose monitoring. So going back to therapeutic inertia, and we are now going to switch and talk about the patient-related factors. Right here, the patient-related factors that contribute to therapeutic inertia. We know that they are many, and including social determinants of health, complex medical history, lots of things, but I'm not going to go into all of them. I really just want to talk about this one component called diabetes distress, just to highlight this issue in case some of you are not familiar with it. So what is diabetes distress? It is the emotional distress that results from living with diabetes. It's exhausting and it's relentless. So that can cause this state called diabetes distress. And if it's untreated or unaddressed, it can worsen and lead to depression. And it's also important to understand how common it is. Many people with diabetes have diabetes distress at some point in their disease. So when people have diabetes distress, it can worsen their diabetes management. And it can increase their A1C, or it can cause more hypoglycemia, overall worsening of emotional well-being. I'm sure most of you have seen this, but it's really important to distinguish it from depression itself. Diabetes distress is particular to diabetes and that burden. People can have depression, of course, as well. Diabetes distress is a little bit different. It's actually more common than depression. And this is important. It's best managed within the context of diabetes care. And the reason is because if it's a burden from diabetes, we want to be addressing it in the context of the whole diabetes plan and trying to reduce that burden. There are ways to measure diabetes distress if you have concern about a particular patient. This is one of the tools. There's two tools. And then there are ways to assess the tool and to measure the level of diabetes distress. There are ways to address diabetes distress. First, having an awareness of it and asking about it, assessing, advising, coming up with a plan, and arranging follow-up. And then these questions can sometimes help you elicit information about diabetes distress. They're general open-ended questions about the difficulty of living with diabetes and how that might impact other areas of their life. It's important, obviously, if someone does show signs of diabetes distress, that we respond to it and talk to them about what it is, name it. Name diabetes distress as a known entity that is common for people with diabetes. acknowledge the difficulty of having this disease, focus on what's going well, and working together to come up with a plan, not creating more burden on the patient. And one thing that I like to do is taking a break, if possible, from this burden. If someone's doing a lot of monitoring or a lot of dieting and has been really strict for whatever's going on with them, see if there's a way that they can get a little break that is safe. And of course, this is going to vary from person to person, but maybe they take a weekend off from monitoring, or maybe they have a day of carbs. I think that there's different ways to do this, and it really depends on what's happening with that particular patient. If you have any questions about that, I'm certainly happy to brainstorm about these ideas. And I think that this slide is one that I really like because it reminds us of what's going on with diabetes, and that we really review these points on a regular basis to set the culture and the tone of how we care for people with diabetes, and that we address the burden, but also eliminate the blame that is often associated with diabetes itself, and in part of the culture of caring for people with diabetes. So the diabetes clinic is really working toward making sure that we have an open and communicative culture here at APD. So I'm just going to review these points just because I think they're important to review, but it's important to understand and to reiterate with patients that type 2 diabetes is progressive and it changes over time. And even when they're doing everything right, it still changes. And to talk to them about the importance of early glycemic control, that getting things done early will benefit them later, and that might motivate them to want to do a therapy early on instead of, waiting a year, etc. That the treatment for diabetes changes over time because of the progressive nature of the disease. It's not because of personal failure. It's a chronic disease. That we often need more than one treatment, and those treatments change. We need to set realistic expectations. We need to talk about the goal and what those goals mean, and why we want those goals, so that we have overall improved health and reduction of complications from diabetes. And we want to talk about the challenges that we face and people's different beliefs about medications and the disease itself. And also, of course, always addressing social determinants of health. So just like there are many contributors to overcoming therapeutic inertia, there are also many contributors to best practice and addressing this really important issue. And it's the same players. So we are doing our work here at APD to overcome therapeutic inertia. As is obvious, I hope at this point, is that we do have an embedded diabetes clinic to have in-depth care of our patients with diabetes. We provide education for staff, clinicians, and patients. We provide diabetes self-management and education and support. We provide clinical management of diabetes for patients. We have an RN who does a fantastic follow-up, and we are working on the flow of patients through the clinic, making sure that we have chart prep done and health maintenance done and tests ordered. And we are also going to be doing chart review of high-risk patients who are caught up in therapeutic inertia and not reaching goals. And we will discuss those patients with primary care providers and reach out to patients to bring them into the diabetes clinic to see what we can do for them. And we are also streamlining CGM ordering and retrieval of data, and that will be in a future education series as well. So there's a lot happening here in diabetes care at APD. We're really excited about it. If you have any questions, or just want to talk, please come find us. Joanne Hayes and Katie Dornman. And yeah, thanks for listening. And hopefully you'll get the next series soon. Thanks.